Welcome to the North American Society. This is a podcast and our first YouTube video of our spine tumor series. And the topic today is basically updates on management of intramedullary spinal cord tumors. We have two world experts with us. Dr. Jallo is the Vice Dean and Physician-in-Chief at Johns Hopkins All Children's Hospital. He's also the Medical Director of the Johns Hopkins All Children's Institute for Brain Protection Sciences, as well as a Professor of Neurosurgery, Pediatrics, and Oncology with the Johns Hopkins University School of Medicine. Dr. McCormick is the Gallon Professor of Neurologic Surgery at Columbia University College of Physicians and Surgeons. He is also the Director of the Spine Hospital at the Neurological Institute of New York, as well as a Co-Surgeon-in-Chief at the Oak NYP Spine Hospital. My name is Sheng-fu Larry Lo. I'm going to be the Spine Director at Northwell Health for the Spinal Oncology program, and I'll be the moderator for this session. So let's get started. For the disclosures, please refer to the separate section in the podcast or the YouTube for the specific disclosures. So for today, we'll sort of go over more sort of interesting updates and esoteric topics about sort of what has potentially changed in spinal cord tumor resections over the past 5 to 10 years or so. And we'll divide it by three separate areas. The preoperative phase in terms of imaging features that guide resectability, as well as the role of tractography. The intraoperative phase in terms of potential newer adjuncts that we might use, such as 5-ALA, ICG, and ultrasound-guided resections, as well as anterior approaches, as well as sort of the updates on the data supporting monitoring. And finally, in the postoperative phase, we'll talk about the newest data suggesting outcomes based off of the extent of resection, as well as the molecular landscape, including the most current guidelines about molecular GBMs, as well as diffuse midline gliomas. So I think I'd love to sort of hear George and Paul's thoughts about this, but I think in terms of MRI characteristics, I feel like we're always in this situation where do we think this is an infiltrating type tumor, such as an astrocytoma, more so on the left-hand panel, versus is this a well-circumscribed tumor like an ependymoma, such as the picture on the right. And I think that there's been newer studies that have been published. This is a great study out of University of Iowa where it was a single retrospective study of 35 patients, but they looked at sort of the patterns that would predict sort of resectability and the difference between astrocytomas and ependymomas. And it's all the usual things that we intuitively think about, such as homogeneous enhancement and a presence of margination on T1 and T2 sequences, as well as the presence of a syrinx. And I just wanted to ask George and Paul about, do they agree with these findings, and sort of, do they have any pearls about sort of what they look at on an MRI to sort of see whether it is of an astrocytic type of tumor versus a well-circumscribed tumor like an ependymoma or hemangioblastoma?
So Larry, and hi Paul, just want to start. For me, when I always look at the MR, and the first question I have is, one, is it a tumor or is it something else? I mean, I think that needs to be answered. If I'm not sure that it's a tumor, I get very concerned and very risk averse, and want to make sure that the complete diagnostic workup is completed before proceeding with any surgical recommendations. When I look at the MR, I'm looking at is it well demarcated? Is there a plane that I can differentiate? Is there a hemosiderin cap that will help differentiate the presence or absence of a syrinx? Because clearly, what in my experience and what we do know is that if there is a good plane, the resectability is much better than those tumors that don't have a plane. The other important thing is I want to know, where is it located? Is it central or is it eccentric, which may help differentiate between the two most common players, ependymoma versus astrocytoma. And then finally, looking for the vasculature if one is concerned about cavernous malformation, hemangioblastoma, or some of the other rarer tumors. Paul, I mean, what are your thoughts when you see the MR?
Yeah, George, I think you're exactly right. It's we had commented earlier that with MRI being so exquisitely sensitive but not as much specific, it sometimes becomes difficult to identify, is this a tumor versus kind of a medical myelopathy or something like that. Usually the clinical presentation differentiates the two, but it can be difficult in some of these indolent, kind of recurring or subacute kind of cases. I think that the slide that's up there reflects it pretty well. Central tumors, well circumscribed, polar cysts, they tend to be ependymomas.
Right.
Whereas the eccentric or not quite symmetrical appearance in the axial image, the little bit of marginal uncertainty at the margins tend to be more likely with an astrocytoma. But what's interesting, I've actually kind of put less kind of content or reliability on my guess preoperatively, because ultimately it's what you see in the operating room. It's what you define under your microscope that determines. And there are some astrocytomas, the subependymal astrocytomas, the subependymomas, those things, the pilocytic astrocytomas that have very nice planes, even though they're traditionally astrocytomas. So I think it's a great exercise, but you shouldn't use it to influence yourself into thinking that must be resectable because it meets all the criteria on MRI, versus the other side of the coin where you say, oh no, that's a little bit asymmetric, so that's not going to be resectable, because all of a sudden you've kind of biased yourself even before you've started your operation.
Gotcha. And one of the things that the study looked at, which was really interesting to me, was that it actually looked at sort of the pre and post-operative motor scores using the modified McCormick scale. And then they tried to figure out whether it actually predicted the histology type. And if you look at sort of the MRI characteristics, if the preoperative McCormick scale was actually poor, higher grade, then it actually favored an astrocytoma, which I think intuitively makes sense, but I just never thought of it that way. And in terms of the postoperative scores, if they tended to have good neurological outcomes, it tended to be like an ependymoma. And same thing in terms of the imaging features. Obviously, if there was good margination, then the patients tended to do better postoperatively. And finally, in terms of homogeneous enhancement, it seemed like there was statistical significance in terms of the having better sort of motor scores postoperatively. Like, does that seem to pan out in your practice as a whole in terms of the ependymoma population tending to do a little bit better postoperatively?
Yeah, I mean, I think so. There's certainly trends in that, and I think on average this reflects it.
Right.
The hard part is, Larry, is how do you distill that down to the case you're doing today or tomorrow? You know what I mean?
Absolutely.
These are statistical distributions. They're averages, right? And you have to make a decision in your operating room on the day you're doing surgery based not only on this background, which can be helpful, but also on what you see and what you experience. I mean, theory and reality are often two separate constructs, and nowhere is that more clear than sometimes what we see on MRI or even their clinical presentation and what we experience in the operating room. So this is very helpful, very useful in that regard.
Gotcha. George, does this reflect your experience too in terms of the pediatric population too?
Yes, I think it does. I mean, I think, clearly, in children, you're more likely to see astrocytomas grade 1 to, 3. Some could be well demarcated, others may not be, and much more diffuse. I think, what I want to stress is what Paul just said. If you're going to go in and say, oh, this is favoring an ependymoma, and I've got to be able to find the plane circumferentially around this tumor, that's not necessarily true, because sometimes on one side, you may have a great plane. Right. On the other side, that plane may not be existent and much more difficult to discern. So you can't go saying, oh, there's going to be a plane, 360 degrees around this centrally located tumor.
Right. Absolutely, very helpful. So then sort of moving on to the next topic, and I think we talked about this a little bit even before the step of saying that this is a tumor or some type of astrocytoma ependymoma, we have to figure out if it's a tumor first. And obviously, already about 10 years ago, there was already a lot of attention looking at sort of DTI tractography to try to see whether we can predict what type of tumor this is. And this is just from a paper that was published from Germany looking at sort of streamlining these lines to try to better understand what the lesion is. And the panel on the left-hand side is actually a 35-year-old female with a demyelinated lesion that ended up getting a biopsy. And the patient on the right is sort of your more traditional well-circumscribed ependymoma. I feel like in practice, at least at our institution, like just as a sample of the type of images that we get, I think in reality, getting that type of picture perfect tractography is oftentimes very, very difficult. And I just wanted to kind of hear both of your thoughts on the role of tractography in terms of differentiating between an oncologic and a non-oncologic lesion, and even breaking that down to within the oncologic realm. Like, do you feel like it's helpful to at least give you a preoperative inclination on whether it's an infiltrating tumor or not, and also ultimately predicting how good those planes are going to be?
George?
I do order tractography on the majority of the patients, but what I found is it's very dependent upon the center that it gets performed at, as well as the technician and the magnet. Every time I order it, thinking, oh, it's going to be helpful in this operation tomorrow, I'm sorely disappointed most of the time. I think the key point, though, that you bring out is tractography for non-neoplastic diseases. It may be helpful there. That's it, because you're not going to see the clear, the shift in the tracks as you would with a neoplastic process.
Yeah, I think it's fascinating technology. I mean, these pictures are great, and again, but it's a schematic, and it doesn't really have a lot of things that we can use in the operating room, as we're doing the surgery. The idea that it might be useful as a diagnostic, as a differentiator between surgical and non-surgical, I think is a great concept there, and what you're showing there, Larry. So I think that's probably the main value of it. But in the operating room, as I'm doing the surgery, you kind of know where those tracks are going to be, and you want to try to stay in the tumor and not violate those tracks. So again, great technology, but it's hard to integrate them into the actual management, particularly for the tumors.
Right, exactly. I think that I completely echo with what both of you said. I feel like the quality control on a per patient basis is quite a hit or miss. And I think ultimately, as Paul pointed out, once we get into the operating room, I think sort of our eyes and our hands are probably the best guide of where those tracks are. So then sort of moving on to sort of the intraoperative adjuncts. What is your experience on sort of using 5-ALA? There's been it's obviously from our cranial counterparts in terms of helping resect sort of GBMs and sort of grade 3 anaplastic astrocytomas. I'll later show slides of this, but there was an interesting paper that looked at sort of ICG and vascular permeability to help guide sort of a spinal cord biopsy. That lesion ended up being actually non-oncologic.
For the support that I need in the operating room, I can't say I have enough experience with the ALA or ICG in the spinal cords, but I'll ask Paul his thoughts on that.
Yeah, I don't have a lot more experience with it, George, Larry. I think there are times anecdotally where I found it helpful. And it's interesting, you come around and you have a good plane, and then there's some areas where the tumor's a little asymmetric and it bulges out, and you're trying to convince yourself that, no, that's not tumor, or, that's spinal cord. And if you get a positive ICG or ALA, that can be very helpful. I would say, though, the times that I've used it, that's been the minority of it. I don't think it's as reliable as with intracranial cases. I am very dependent on the ultrasound, and I, in particular, making sure you have adequate exposure. Making sure, to me, that's the biggest limitation or mistake that I think we tend to, is that we don't get adequate exposure beyond the margins of the solid tumor pulse, and the ultrasound really allows us to say, okay, you are or you're not, and for me that's been very helpful, and I'll use it repeatedly during the surgery to make sure that I have good exposure and that I've taken everything out.
Gotcha. Okay, I feel like, in terms of, I kind of agree with these adjuncts that I feel like the role is not quite as helpful. I think in these two instances, for example, this was a patient, actually, a 24-year-old female with a potential drop metastases from like a supracellular germinoma. And I think their question was whether this trace enhancement that they see in the cord there was potentially tumoral, and I think they used ICG. This is a study from UPenn and pre-proofs. They used ICG to kind of locate that area that was quote unquote leaky in terms of the contrast enhancement and biopsy that area. So I thought that was pretty novel, but I agree that perhaps in terms of your conventional tumor resection, that it may not be very helpful. specifically looking at sort of like non-enhancing tumors like subependymomas, I found that this is actually a study from Italy where they use contrast-enhanced ultrasound to try to help guide resections for subependymomas. If you take a look, obviously on the pre-op MRI, really there's minimal contrast enhancement. On a standard 2D ultrasound, you can see the bulged tumor portion and on the axial cuts. And then what they did was, they used sort of a bubble contrast enhanced ultrasound to kind of see the delayed uptake in the tumor. And whether this actually helped guide the resection or not is a different story. But what do you think about this type of technology in terms of guiding resections for tumors where the margins may not be quite as clear, potentially like an infiltrating tumor, or even sort of a subependymoma where it doesn't have really clean margins?
Yeah, and so sometimes, I'll grab this one first, but I think this is great. I mean, I think, because it's in real time, tachography or tractography, that's preoperatively, it's not usable and updatable in the operative. This is, and I think it's more effective, more specific, more reliable than regular ultrasound. And so I think to kind of guide you in terms of your resection or see how complete you are, or where does the margin of the tumor end and the spinal cord begin. To me, this is very useful and I think very promising because, again, it's real time and you can update it. It changes as things change in your operating theater.
Gotcha. What do you think, George?
Sorry, I agree with Paul completely. I think this technology is much more helpful than anything else in the operating room or preoperatively.
Gotcha. So potentially something on the horizon there. Another sort of more interesting intraoperative approach is actually anterior approaches. I feel like obviously 99% of intramedullary tumors, we take a posterior approach. The panel on the left is actually a case of a capillary hemangioma from the David Grant Medical Center. And the picture on the right is actually from our own Dr. McCormick here, where he actually had a beautiful video of resecting a hemangioblastoma that was published in the Red Journal. And I wanted to kind of hear both of your thoughts on your experience in terms of these anterior tumor resections, as well as what are the pros, specifically as it pertains to like the venous drainage and sort of the anterior spinal artery, because it's such an unconventional approach compared to our standard myelotomies for posterior-based intramedullary tumor resection.
Paul, you take it.
Oh, okay. Well, yeah, I mean, I think, like it or not, I think, the main approach is a posterior, midline myelotomy. I mean, I think that's probably 95%. But, there's an ambivalence about it because virtually every patient has a postoperative proprioceptive deficit as a consequence of that surgery. And, and I spend more time having that conversation with patients prior to the surgery. And it's still the first thing they say, you take the whole tumor out, they're moving their legs well, but they say, my legs are numb. And that comes at your hands. And so our technology, technically in terms of localization, in terms of approaches, in terms of dural repair, in terms of reconstruction, has opened up these avenues so that when a patient who has a ventral quadrant or ventral peel location, like you're showing here, Larry, or maybe a hemangioblastoma, I think to be able to utilize that technology to do an anterior lateral approach and avoid a midline myelotomy, I mean, I think it's just a wonderful option to have. And we're so, I think, grateful to general orthopedic surgery, neurosurgery, spine surgery for developing the technique so much that we have this facility with anterior lateral approaches that can reduce the morbidity of these operations for a small percentage of patients, to be sure, but they're very important.
Absolutely. All right. I mean, I highly encourage our viewers and listeners to look at the video in the Red Journal that Paul published. It's a fantastic operation. The reconstruction is beautiful as well. George, do you have any experience with these sort of anterior transcervical approaches?
I will say, Larry, I think I've seen it once, and really, it's for very limited types of pathology. I think, as Paul said, it's an anterior hemangioblastoma or maybe, and I've done it for an endodermal or a neuroectodermal cystic, intramedullary cystic tumor that with the origin anterior to the spinal cord. So very limited. And the other 99% of the operations for spinal cord tumors are going to be done from the posterior approach.
Gotcha. All right, I completely agree. I think in terms of, I think this is always, I think at least for your average tumor surgeon, that it's always sort of a very difficult topic on sort of how do you manage monitoring changes, and are they predictive of outcomes? And this was actually a prospective study that was published from Japan across like 13 or 16 medical centers, looking at spinal cord tumor surgery between 2017 and 2019. If we specifically look at the intramedullary arm, they had 81 patients, consecutive cases, prospective data collection. And basically they looked at the true positives, false negatives, and true negatives of the monitoring and predicting a postoperative deficit. And they also specifically defined sort of a rescue category, where these were patients that actually had a monitoring change that they defined as basically below 70% of the baseline transcranial motor evoked potential threshold. And they basically either stopped the surgery, gave steroids, increased the MAPs to try to see if they can get the signal to come back. And postoperatively, the patient had a minimal deficit. They defined that as sort of a rescue case. And I think that if you look at sort of the baseline characteristics in between the patients where they had a deficit versus they were able to be rescued, really, if you look at your basic demographics like histology type, age, gender, BMI, there was really no difference between the two groups. And one of the questions I had for our two panelists was, do you have a sense of a feel of in which patients do these monitoring changes kind of represent a real stopping point?
So, for me, Larry, I do use the transcranial motor evoked potentials as well as somatosensories. I rely on the somatosensories. It's only, when I'm doing the myelotomy. And once I'm starting to work on the tumor, I'm going to rely on the motor evoked potentials, whether it be the muscles or the epidural D wave that is measuring the corticospinal tract in real time. I think it's using the combination of both, the amplitude of the D wave, the corticospinal tract, as well as the presence or absence of the target or muscle organs, helps guide the resection. Now, there is a lot of asterisks and caveats.
Right.
Am I going to stop the resection if I lose the motor evoked potentials during the resection of a hemangioblastoma? No, absolutely not. Or if there's a tumor that has a very good plane and I'm almost complete, unlikely. I'll probably, just try to finish that off. But if I'm doing a tumor, more of a diffuse or infiltrative tumor, as seen in children, yes, I'm probably going to stop once I start to see a decrement in those muscle evoked potentials. So I think it's very case dependent and individual to that case, the histology as well as the preoperative motor exam.
Gotcha.
Yeah, I think it's a controversial area, and I look at it as more of a tool than a treatment, and so as a tool, people use it differently. They have different interpretations. They have different use, and so, like the term predictability, for example. I think there's no question that changes in intraoperative SSEPs or motor evoked potentials, whether transcranial or just intermittent in the muscles, they do correlate with outcome. I don't think there's any question about that there is a positive correlation. But how do you use that? And so the idea, if you're going to, in other words, be very aggressive, for example, or keep going until you have a drop off in your motor, I mean, the cow's out of the barn. The damage has been done in many instances. And so that's a little bit of we have to be a little careful about that. And how many times do we get a false positive? SSEPs almost always drop down with a myelotomy.
Right. Of course.
And motors sometimes can be, a little bit jumpy too, but the anesthesia, what do they call it? Anesthesia, fatigue over time. And I think so a lot of people are possibly allowing their surgery, their goal, their outcome to be influenced unnecessarily by that, in either direction. So how many times do we have a false positive that we stop the operation and not achieve our operative objective when in fact we could? So I think George is very, I think, sanguine about it. He's done a lot of writing on it. He's shown a lot of leadership in that. It's helpful as a tool, but it depends on how you use it.
Gotcha. Then specifically, I guess, obviously it's a case-by-case basis, as you guys have both pointed out, but in terms of like a discrepancy, so let's just say that you have like the motor evoked potentials are potentially out or like 20% of baseline, but your D waves are still completely robust, no change. If there's a discrepancy like that, sort of, obviously I know that there's no sort of one size fits all sort of paradigm, but what are your thoughts, George, in terms of how you interpret those results?
Again, Larry, I think, as Paul said, it's a tool. So, I'm going to pause, see where I am during the resection, see, is there a good plane or not? And speak with the anesthesiologist, make sure everything's optimized. And then using both the D wave as well as the transcranials, probably continue in that scenario that you just pointed out. Now, if it starts to continue to go down and I'm struggling and I don't have a good plane for that tumor, I may consider, aborting and halting the operation at that point. Gotcha. But it's really dependent upon, the histology, whether the presence or absence of a plane, and the condition at that time.
Gotcha. Okay, very helpful. All right, so moving on to sort of the next topic, I think similar to our intracranial counterparts, now that we have a little bit more sort of prospective studies and long-term data, it seems like obviously, as anticipated, if we translate that data to specific spinal cord tumors, that there seems to be obviously a relationship between sort of gross total resection versus subtotal resection versus just an open biopsy in terms of mortality, as well as recurrence-free survival. This is in sort of the glioma population. And sort of based off of this type of data, sort of how, I guess, tying it together with the monitoring piece, do you guys have any sort of tips and pearls on sort of which patients do you kind of push the monitoring changes a little bit to try to really go for that gross total resection?
In my experience, never. There are two rules to surgery for me, two goals. First is protective. The second is to take the tumor out, and it's ordered. If I'm putting them at risk by dissecting an area that I'm not so clear about or is not a clear margin, especially if I have changes in SSEPs or transcranial motor or direct, I stop. To me, it's these tumors are so indolent, they're biologically so benign, and that to me, you want to manage these folks as best you can. Now, there's a spectrum, and there can be more biological, activity in certain ones than others. It's hard to know that at the index operation, which is your best opportunity for gross total resection. I think in the patient who might recur again and again, who you're doing the third or the fourth operation in a period of a few years, you might push the envelope a little bit there. But for me, it's never to the point where I'm going to keep operating until I get a loss of potentials.
Gotcha. Yeah, Paul, I when I speak with the families that, whether it be a child or an adult, I always, they're like, you're going to get it all. I'm like, listen, my intention is the maximally safe resection. Is that a gross total? Possibly. But it will be the most that I could take out safely and do no harm, or do minimal harm anyway.
Absolutely. All right, very, very helpful. All right. So then looking at our final topic of the evening, which is basically sort of the molecular, as our understanding of the molecular genomics of these tumors get better, I feel like more recently, this entity of sort of diffuse midline glioma is starting to be better understood in the spinal cord tumor population. And just to briefly summarize, basically, if you have a H3K27M mutant patient, independent of histology, those are considered grade 4 tumors right off the bat. If you look at this paper that was published in neurosurgery from Capital Medical University in Beijing, it shows that these patients invariably do quite poorly. Whether you get a complete resection versus subtotal, it doesn't matter if you give them radiation, it doesn't matter if you give them Temodar, it doesn't matter if you give them combination surgery, radiotherapy, or surgery, radiotherapy, and chemotherapy, or surgery alone. These patients invariably do very poorly. So knowing that sort of there's this sort of relatively speaking newer entity or subgroup of patients that do very poorly, has this sort of affected your management strategy in terms of how aggressive you are in the operating room, especially if you have sort of a preoperative suspicion that this might be a diffuse midline glioma?
Well, I mean, I think it's a work in progress. This is great technology, and the idea that we can better define the natural history or the clinical response to various treatments based on individual markers or biology of the tumor, I think is great, and I think is kind of where the future is going to be. The problem is a little bit is that we don't have access to this information when we do our index operation. I mean, this is something that takes a month or 6 weeks or something like that to get that information back, and you're already done with your surgery.
Right.
I mean, I think it's too early for prime time in the sense of having an impact on what we do. But I have no doubt that in the not too distant future, it will be very helpful in that regard, particularly if we can get that information elsewhere before we do the surgery so that we can tailor the operation, kind of the risk assessment to the individual patient. I think this is great technology and really the future of what we do.
Gotcha.
And Paul and Larry, I totally agree. I mean, I think it's not ready for prime time, real time today. But the way I tailor it is in the operating room, I get it frozen for every case.
Right.
If it suggests a malignant astrocytoma, I'm already slowing down. In the back of my mind, do no harm. The last thing you want to do is incur a deficit, and that patient will never recover before their disease progresses or succumbs to it. And that's really from being, previous experience where, as you said, you do a biopsy, you do, we call it whatever you want to call it, gross total resection of the glioblastoma of the spinal cord. The outcome's no different. The survival is no different. So, if I do the biopsy, it looks like it's going to be malignant. I am already starting to slow down, just making sure that we get enough tissue for an accurate diagnosis and enough tissue to send off for the molecular analysis.
Gotcha. And I think just to kind of end with sort of like a case, I feel like, especially more recently, as the WHO has updated their guidelines, all of the intracranial glioma diagnostic criteria, I feel like, are being applied to the spinal cord diagnostic criteria. And I've had several patients. This is just an example of one where this was like a 67-year-old dentist that's had this lesion in the T11, T12 area forever. I think I followed him for like 3 years. And finally, he maybe started to get a little bit more symptoms in terms of tingling. And there was some question about the diagnosis. So we basically went ahead and did a duroplasty as well as a biopsy just to get a diagnosis. And of course, the biopsy comes back as grade 4 GBM based off of the most recent published C-impact now criteria. There's 6 update looking at sort of TERT as well as EGFR mutation as being sort of similar to the midline gliomas, those independent of histology right off the bat. If you have a TERT mutation or EGFR amplification, we call it a GBM. So obviously, a lot of times for these patients, as the spine surgeon, you're the first person that's kind of giving the patient this news. I'm wondering sort of what your experience with this has been in this realm, because I mean, the 2 or 3 patients I can think of, they're actually doing quite well. And I feel like anecdotally that they're not behaving like a GBM where we expect them to really succumb to their illness pretty quickly. So I wanted to see if you've had sort of experiences like this where essentially the pathologist and the neuro-oncologists have kind of overridden the clinical course based off of just molecular data alone.
I'll let you answer that one, George.
So Larry, I think, I mean, you nailed it right there, right? I mean, you were following this gentleman for 3 years,
Right.
before the biopsy. So clearly, there's no way that is the clinical history of a malignant tumor. Yes, the pathology is the pathology. They've looked at it. And if you're going to go in there and say, oh, this is you've got IDH wild type, you're going to be dead in like 9 months. It's possible, but at the same time, he hasn't shown that clinically. He's going to look at you with two heads and say, Doc, why now? What happened from like 3 years ago when I first met you? Right. So I think, as Paul says, it's newer technology. We're relying on the intracranial, outcomes for these. So time will tell. I mean, I think we need more cases like this to better understand them.
It's really up to the younger guys like you, Larry, to put this in some perspective. I mean, that's George and I, we're technicians. But guys like you got to change this field, and do this research and make these innovations because they are so different, and it will make a difference. But we're just now beginning to see, I think, the promises and the fruit of this. So more to come, I guess.
Gotcha. Great. So I think this wraps it up. We don't really have an audience, but Hitchon is actually with us. He is actually the pioneering brain power behind all of these podcasts, as well as our first YouTube video. So I was going to put him on the spot and see if he sort of had any questions for our panelists or for myself about sort of any of the topics that we had covered.
Oh no, Larry, George, and Paul, thank you so much for doing this. We all appreciate it. This has been a very interesting collection of the most cutting-edge updates in this realm. Certainly, lots of food for thought and judgment calls. But thanks again for doing this and taking the time. We all appreciate it.
Sure. Thanks for asking us.
Absolutely. I'd like to thank our panelists. Thank you all for listening. Please tune into our next episodes in our spine tumor series. And in terms of the specific references for a lot of these studies, we'll make sure that they're available either in the podcast description or the YouTube description. All right, thank you guys very much.
Great.
Thank you.
Thank you, guys. Nice to see everybody.